Hello and welcome to The Art of Aging, which is part of the Abundant Aging podcast series from United Church Homes. On this show, we look at what it means to age in America and in other places around the world with positive and empowering conversations that challenge, encourage, and inspire everyone everywhere to age with abundance. I am super excited today because we have our first bioethicist on the show today. This is Dr. Anita Ho. Dr. Ho is a bioethicist and health services researcher with a unique combination of training and experience in philosophy, clinical and organizational ethics, public health, and business. By the way, she's also a classically trained pianist with a master's degree in piano performance. So I bet you she's still trying to decide what she's going to do when she grows up. Anita is currently an associate professor at the UCSF Bioethics program and a clinical associate professor at the Center for Applied Ethics at the University of British Columbia. So go Canadians. She's also the vice president of ethics at the Northern California Division for Common Spirit Health. As an international scholar and author of more than 90 publications, Anita is an elected fellow of the Hastings Center. Her current research focuses on the ethical dimensions of utilizing innovative and artificial intelligence technologies in healthcare, research and trial design ethics, support of decision-making, and end-of-life care decisions. She's particularly interested in systemic and social justice issues arising in healthcare. Her broader research areas include trust and decision-making in clinical and research medicine, family-centered care, healthcare resource allocation and disparity, organizational and system ethics in healthcare, cross-cultural and global health ethics, professional patient relationships, ethics education for health professionals, disability and pain experiences, and various concepts of autonomy. Oh, this is going to be meaty. I'm going to love this. Her book, Live Like Nobody is Watching, Relational Autonomy in the Age of Artificial Intelligence and Health Monitoring, was published by Oxford University Press in May 2023. And Anita, thank you for making time to be on the show. Welcome.
Thank you. Great to be here.
Thank you. And just a reminder that this podcast series is sponsored by United Church Homes' Ruth Frost Parker Center for Abundant Aging. To learn more about the center, including our annual symposium in October, visit unitedchurchhomes.org/Parker-Center. So, Anita, the first question I want to ask a lot of our guests is that, you could be doing a lot with your talents. You could be obviously playing Carnegie Hall. You could be, there's a lot of things you could be doing, but you're in this area of study. How did you become fascinated with bioethics?
Yeah, well, thank you for that introduction. And you mentioned earlier about music. I initially actually wanted to go to music school. I was born and raised in Hong Kong, and my parents were small business owners, and they didn't have college degrees. And so they thought, you're not going to be a pianist or a musician. And they were small business owners and wanted me to study business. And so I went to Canada and was studying marketing. And it was actually when I was required to take a non-business elective that I stumbled upon a course in philosophy called biomedical ethics. And I just thought it was really interesting. They were asking all these questions that I hadn't really thought much about, like how do we allocate resources when people get older and possibly get really, really sick? And can we force people to get treatments if they have mental health issues, or if they cannot make decisions for themselves? Can we make decisions for them? Or how much risk can we allow people to take if we don't feel comfortable with the potential cost in the society and for others? So I took that one course and I loved it. And I thought, that's what I want to do when I grow up, at least for a while. And then here I am still doing that.
Well, I have to think, was it always called bioethics? How long has the word bioethics been around? And before there was a term bioethics, how would people look at those issues? How would they be framed?
Yeah, great question. The term bioethics really came more into our more common usage probably in the late 1960s and early 70s in the US, when people started to really think more about ethical issues arising in research and in healthcare. This is particularly after Second World War, when we thought that, we can't necessarily just rely on physicians' goodwill to make good decisions, particularly given some of the Nazi experiments that were done. Even though the term might not have been used until that time, I would say that probably many of us actually encounter what I will call bioethical issues on a daily basis. I already mentioned some examples. I think especially now with technologies being more advanced and possibly more expensive as well, we often have to even individually make decisions in terms of what healthcare treatments we would want, particularly when many of these technologies sometimes would have uncertain risks and benefits. This is especially as we get older and we may have more and more different conditions as well. And high-tech healthcare may sound really good in some ways, but it does impose other kinds of burdens. So how do we decide whether that we want to take on those burdens, especially at end of life, and especially for, let's say, more experimental types of treatments as well? And I think that because healthcare is getting more and more expensive, especially in the U.S., there are also justice questions in terms of how do we make sure that we can allocate resources responsibly and fairly, especially when we know that with systemic inequalities, there are some people who have always been left behind. And how do we make sure that they are not further disadvantaged because they don't have access to healthcare?
Is there a general agreement on the principles around bioethics? Is there a quantified sort of boundary of what is ethical and what is not?
Mm. Yeah, so at least in Western bioethics, we often talk about these four principles in places that really focus more about people's own independence and their own rights. We often start with thinking about what would be respecting people's autonomy, so that I get to make decisions about my own healthcare, just like I can make decisions about finances or other kinds of matters that are important to me. But then in healthcare, we also have, the two kind of correlating principles about beneficence, which is to make sure that if we are going to provide healthcare, that we are providing benefits to people, and that we do no harm, so non-maleficence. That when physicians are doing things, which is why the Nazi experiment that I mentioned earlier was so traumatic for many people and problematic, of course, from a professional ethics perspective as well. Do no harm is often like the number one thing, even if we don't know for sure that we can give people benefits or promote their well-being, at least we cannot harm them intentionally or at least in ways that are foreseeable. Yeah. And then I mentioned earlier about justice as well. So how do we make sure that we're being fair to people, we're not discriminating them? So those are kind of boundaries that we think about. But of course, sometimes what happens too is that they conflict with each other.
Yeah, and that's actually something that's really kind of you really keyed things with the World War II and Nazi reference, because let me maybe pose this question that maybe I've thought about once or twice. We know that horrible things were done during World War II, especially Dr. Mengele's experiments and things like that. Yet those experiments achieved scientific outcomes, and those outcomes may be useful in supporting positive health care for other people. Is it ethical to use those outcomes, or do we have to discard them because they were achieved in such a horrific way?
That's a really great question, right? So sometimes, of course, lessons that we have learned, we cannot really unlearn them. So in many ways, of course, we hope that the lessons can still stay with us. But I keep thinking that a big part of the lessons that we really should be learning from the Nazi experiments is really how we should not be violating people's rights. But what would count as people's rights when we are thinking about healthcare decisions and healthcare research actually is not as clear as we might think. After the Nazi experiments, we talk a lot about informed consent, whether it is medical treatment or medical experiments. But in many ways, there are also questions we have to think about in terms of whether we really should allow people to just opt out of, let's say, their healthcare information being included in data analysis, if we think that we need everybody's data to make sure that we have representative data so that when we try to improve healthcare, we can improve it for everybody else. But I do think that you've raised a really important question. Somebody was asking me something very similar at a conference a few days ago in relation to large language models and other kinds of data we are collecting from people. It may not be the Nazi kind of scale, but then it may still be unethically collected people didn't realize that their information has been used. But now that we have got some insight from the data, should we just discard them? And
Yeah.
I think it depends on the scale of the harm that has been done to people and how much of an atrocity it really is. So it's case by
Yeah.
case basis, perhaps.
Yeah. I mean, so many things are going in my head around these kind of quandaries that we face. I mean, I know somebody had introduced this philosophical concept of communitarianism to me, where
Mhm.
I guess that, and I'm going to maybe fail at this, but I will pay attention to you as a person until whatever we're doing affects the wellness of the whole. So, if we're thinking about
Mhm.
healthcare data research, and we want to we want to collect a representative sample of a
Yeah.
wide range of people, and yet we don't have enough from a certain group. And let's say we find a group of data somewhere and it's not opted in or whatever. I mean, that's a tough decision around the benefits of that data supporting a potentially beneficial a set of research, and
Mhm.
then that violation. I mean, these are not black and white issues, right?
Yeah, no, and I think this is really, to me, a system issue as well. So you can imagine, you and I are both Canadian and in the US too, right? When I was conducting a research project in Canada in the last few years on research consent and so on and so forth. And it was really interesting, is maybe partly because the participants were in Canada, which enjoys publicly funded healthcare, and people would not be denied healthcare coverage. Many of them kept saying, "Oh, I'm happy to donate my data and my samples and information for research, as long as we know that there would be the community benefit," and kind of like the communitarian way of thinking. But as long as we are worried whether some people may not actually benefit from healthcare, then we're not too sure. And I think one concept that is really important for us to think about too is the learning health system. So as we now have the ability to collect more and more information, even when patients are in the hospital, are in the healthcare clinics and healthcare setting, and not just in research, we have to consistently ask ourselves, should we have consistent quality improvement, use our data and see how patients are faring? The tricky part, and I think in that response to your comments a little earlier, is not even just whether people are consenting to participate in research if they don't trust the system. There are many people who may be, because they are underinsured or uninsured, especially in the US, or in Canada, they don't trust the healthcare system. Let's say many people in the indigenous communities, they may
Yes.
not even go and seek care. So their data may not be included in the first place. And if we're really trying to improve care and we don't have people's data, or they don't trust us to allow us to use the data, then we have this, what I consider to be a double-edged sword. We want people to trust us so that they will let us use the data, but they may not want us to use the data if they don't think they can benefit from research. So we have to really think about how do we actually make the system more accountable so that people can actually trust us with their information and the data.
Yeah, and I definitely want to get to some of the scenarios that I know that you and I had talked about before. But
Mm.
I got to tell you, what's really kind of going through my mind right now is a world that at least I have been looking at very closely for the past 6 or 7 years, in this world of social determinants of health, and
Mm.
particularly the impact of social determinants on preventative health and wellness. And we have a
Mhm.
whole spectrum of non-clinical influencers that
Mhm.
impact our health and our wellness.
Mhm.
And there are opportunities, at least us in senior living and in supportive care for people with functional or other disabilities. We find that if we discover one's motivation, if we discover one's underlying, I guess, mental, health, then those understandings allow us to develop more personalized models of care. But yet we need to build that trust and capture that data in order to deliver that care. I mean, no one is going to say I'm lonely, or my son, or my son tries to take care of me, but he can't lift me up, or
Mhm.
even in fact, one of the most predictive non-clinical pieces of data that is predictive of your future health and wellness is your credit score. But we know that at least in my experience, that is data that is not touched. We do not pull that data. That is not brought into that. But that's sort of another example of these ethical decisions, right?
Yeah. Well, I would need another whole podcast to talk about using credit score because I mean, and I love that you mentioned about social determinants of health. After I've been working in the healthcare system in academic bioethics for a long time, I actually went back to school to UC Berkeley about 10 years ago to get a master's in public health. Partly because I think actually a lot of even individual bedside ethical issues in the hospital setting are really very much about broader healthcare issues and broader social environmental issues. And so the credit score part, I won't say too much, it really ties to people's economic situations. Very often it ties to their education level, but it may also ties to racism in terms of how may some people be consistently denied employment opportunities or other kinds of opportunities because of, even if it is inadvertent racism. And so that for some people, then they may consistently have a lower credit score because, we may be reporting people more easily as well due to their background. So how do we actually determine what data would be most relevant and most helpful is, by itself an engineering data question, but I think also has the ethical dimension to that as well.
Yeah.
But I do agree with you that very often we do want to have as much data about people as possible to be more, like you said, personalized and more the precision kind of ways of thinking. But we do have to really think about what kind of information actually is valuable, what kind of information is noise.
Right. And let's switch gears a little bit and just talk about just how the healthcare system really, at least in the United States, engages with people today. I mean, it's not really a healthcare system in my mind; it's a sick care system, and it's a system where there's not enough workforce. We have an aging society. Any demand we see for healthcare services today will probably be 10 times the demand in 10 years with no no vision for a workforce increase, and we have all of these different wonderful thoughts about how we might thread a needle or a silver bullet or whatever you want to call it by doing things like moving care into the home as much as possible. So we talk about these concepts like hospital at home, or I mean, and this, I think, as you explain it, nobody wants to be in a hospital. Nobody wants to be in a skilled nursing facility. We know that the jobs of hospitals are really just to stabilize you until you get to the next most appropriate place. And then, oh, well, let's send them home. That's great. But that, in my mind, just opens up a whole new kind of dynamic, because then we talk about the impact of the needs of the healthcare system, not just on the patient, but on their families. And I'm wondering if you can talk a little bit about maybe some of the ethical issues we have to unpack around the idea of send them home or support them care, or just this concept of hospital at home.
Yeah, and I think actually this ties really well to some of the principles that you were asking me about in bioethics. So like you said, right? I mean, hospitals are not good places for people to get better. I mean, to stabilize you, yes, but hospital infection and noises and the unfamiliar environments for many people in the hospitals are actually, often adding more stress to people more than anything else. And so people want to be home. They want to get home as soon as possible. So from a respect for their autonomy, their agency, we want to do that. It promotes their well-being, so it sounds great. There is that justice component that I think we really need to think more about from a broader social perspective, because health systems are then also shifting the cost to individuals. Hospital care is very expensive. And if we can somehow allow people to be cared for at home and be monitored at home, then hopefully you would heal better and it would be also cheaper care. In some ways, we think that this can also be really good for people's privacy, because now, instead of wearing those portable hospital gowns that you can, be in your own environment and, determine your own schedule and so on. But we are then shifting the cost on people themselves. So depending on how your follow-up appointments, medication reminders may be all set up, that's a lot of burdens on people, especially if they may have some kind of cognitive decline or if they don't have family support. And hospital at home often also requires various kinds of technologies for people. So it may not be this whole quiet, calm, and peaceful environment that you may expect your home to be as well. There may be now all of a sudden this kind of technological intrusion, if you may. So how do we really reconcile the privacy matter and also to see how exactly, if people do live with their family members, how exactly is this really going to help versus add even more burdens on family members as well, who often, of course, as you might know already, are women who may have their paid employment outside already and may have children they're caring for already. So how may we be supporting also family members who may be taking on some of that burden as well?
Yeah. So let's talk about some best practices here, because I think you outlined a number of the different, factors that should be happening in the decision making. I imagine, a parent or a spouse being sent home, and somebody may have a job where you can't really take the time off, or then there's the educational component of things, and you have to learn this whole new language. I mean, I used to think that. Well, I don't know. I think, because, the medical world has its own language. I mean, and I know, health literacy is even a challenge for me. I mean, I don't know what 120/80 means, even mind erased. And so there's a lot of different factors there. And it's even just, I don't know, just that bridge of understanding one's clinical condition, understanding the terminology, is just such a first big step. I mean, where do you think things are falling short, or where have you seen, I guess, some best practices of things that are being done right? Right? Who do you think has got it, or where have you seen examples of things where that these are kind of more gold standard programs for patient support or family support in the healthcare system?
I'm not sure about the gold standard yet, partly because we're still relatively early, but I would say a few things about what you were just talking about. And some of this I mentioned in my book in relation to home health monitoring as well. You mentioned about health literacy, but I think as we use more and more technologies, we also have to think about digital infrastructure and digital literacy, because especially if we're using them for older adults, many of them may not have been very used to the technologies. So how do we use, for example, human-centric design and really use like journey mapping to see how may all the occupants of that particular place that you are monitoring the person will be using or will be interacting with the technologies that are being used. Because sometimes the people may not even know how to turn on and turn off things. I generally think that, I don't know whether this is gold standard, but at least helpful is, especially at the beginning, if we are using the hospital at home or other kinds of monitoring, to really assess what people's readiness might be from the beginning. What is their health literacy, like you said? What may be their digital literacy? Would they be able to turn on and turn off the machines? And for example, are alerts being put out there really relevant to the person's care? Because one thing that we might find too, and we have seen that in various studies, that sometimes that older adults or the family members may actually feel very anxious or burdened even by some of the alerts. So the sweet spot might be to really figure out how do people interact with the information, what information they think would be most important for them, what information would really make a difference in terms of what their behavior should be, like standing versus sitting and so on, or the medication, or what information would really help the clinicians to support the patients. Because otherwise, sometimes we may be thinking, oh, all the charts, all the numbers will really give us information. But that may, in some cases, be too much information that can overwhelm people more than helping them.
Wow, that is a great That is a great statement because, I remember, when the Fitbits were popular and I was talking to
Mhm.
one of my doctors, he's like, oh my gosh, if I have another patient coming in with like 8 months of Fitbit data on a USB, but it goes the other way around. I mean, because so two things are going in my head right now because, in terms of technology and support of technology for longevity and aging,
Mhm.
you get into this world of, first of all, the ability for more and more clinical monitoring and for yourself
Mhm.
to really see more, or your loved one. I mean, you can, I get people all the time saying, "Oh, could I sell a remote patient monitoring tool for the families of your residents?" And I'm like, oh my gosh, I
Mhm.
think the only people that would use them are the people that just get freaked out all the time about, is my mom okay? And this is just layering yet more things in, more data points in, just like you said before, to feel anxious about, right?
Mhm. Yeah, I think sometimes that the more information we have, especially if they're not really relevant, there's some devices that just keep sending us alerts. And I have to say, when I'm combining my marketing hat and my ethics hat too, that is a fantastic business model, right? Like if you have models that don't seem to be, dinging at all, alerting people at all, you think that it's either not working or it is not really doing anything for you. But a lot of alerts can really make people very anxious. And it also depends on whether the target users are really like family members who want to monitor or the people who are being monitored, because they may also have different risk acceptance level as well. Family members sometimes may be more risk averse compared to older adults who might think that the daughters or sons are just, too worried and always wondering about what they're doing, what they're eating or not eating, and so on and so forth. So we have to think about, I think, the workflow even for your staff members. What happens if all these machines are beeping at the same time? How much is that going to also affect their workflow, affect family members' days as well? Because you mentioned about your doctor talking about Fitbit. I can imagine, especially if people are being monitored all the time, they may also think that, well, that means that my doctor has all my information. Why haven't they called me yet with all those, bells
Right.
and alarms going off, right?
Right. So there's ways to unpack. I know that, more data, more risk, because why didn't you see
Mhm.
this? Why didn't you see that? And then it also kind of speaks to the human-centered design element that you spoke to before,
Mhm.
that in that designed environment, if these things are alerting or queuing or what have you, is that what is the associated feeling with that? Is that anxiety? Is that what? There's a lot you can get into there. And I want to kind of unpack two more, maybe just areas with you along these lines, and I want to kind of frame this back to that idea of an aging society, of a
Mhm.
society where more people, I mean, 2/3 of us will need long-term care and support services, either for a short time or for an extended time at some point in our lives.
Mhm.
And we have a system where we can't build buildings fast enough. We don't have enough caregivers. We do have this thought that technology is going to be able to fill the gaps here, and we're seeing solutions like let's say I know that we are going to be testing Alexa, and we can certainly bring something like an Alexa into different, into resident units or into individual homes. It's a secure communications hub. We can do text messages on it. It's easy to use. And
Mhm.
and and generally, I think that, at least in my observation, sort of the anxiety about Alexa always listening and things like that, that seems to be, at least in my observation with older adults, it does seem to be on the decline. But what is associated with that communication tool also is this idea of behavioral monitoring. And
Mhm. Mhm.
you see, I've seen different systems out there where it could be a camera system,
Mhm.
or it's I think that it's called millimeter wave pulsing, where it's kind of like radar pulses that go through the home, or it could even be an Internet of Things device where you're turning on and off the lights using an Alexa,
Mhm.
but somebody who may be providing supportive care for that individual would be able to see the data collected by those systems, so that if somebody has a baseline set of behaviors and there's a deviation from that baseline, that may signal someone to have an alert. So the example that I often get presented with is that, let's say, your father, there's a communication hubs in the kitchen, or somebody engages like with an Alexa, wait, start my day routine. And
Mm-hmm.
dad always, between the hours of 8 and 9 for the last 3 months, he goes to Alexa, or he comes into the kitchen, and there's some sort of activity in the kitchen. And now on this particular day, it's 9:30 and there's been no activity yet. And that may signal, oh my gosh, I should probably give a call, or I might be able to check in. And it could be an
Mm-hmm.
emergency, or it could not be. So
Right.
I'm wondering where this strikes you in terms of the benefits of fall detection, or what have you, but with this sense of something that will record your day to day behaviors.
Mm-hmm. You mentioned my book earlier. The title is "Live Like Nobody's Watching," right? So even as you were describing it, I was thinking, yeah, nobody is watching in the sense that we're not talking about humans watching you. So there's nobody watching, but at the same time, you have to just pretend that nothing is watching you, right?
Well, I
When
mean,
you
for
make
crying out loud, we've got phones on ourselves all the time. I
totally,
mean, anybody who's worried about
totally,
privacy and what it's crazy the
yeah.
data that your phone sends to marketers and all sorts of people.
That's right. That's right. So I mean, I think that especially for older adults, it's really interesting, and this is why I think that from an ethical perspective, it's a really fascinating question. Is when people are getting more and more vulnerable in terms of the physical and cognitive decline, that it is the best time for us to monitor. Right? I mean, if people are healthy and generally speaking, if they fall, they can get up and they know that they're at risk, we shouldn't have to worry too much about that. And people should be able to take care of themselves. It's when they are having cognitive decline, they can't remember to grab the whole bar or call for help and so on, that we want to monitor them. But those are also the times that people cannot remember or know to consent or refuse consent to be recorded. So as a society, I think we really have to ask ourselves a question. And I'm not saying that we shouldn't do it, but just I think that these are fundamental questions that we should have for ourselves as we get older, whether we would be willing to say, privacy versus my safety, I would value one more than the other,
Hmm.
especially if I can trust who would actually have my data, who would get to
Right.
use it. If it is, a particular company's device, is the company going to own the data and that they can use it for other product production, promotion, quality improvement, and so on?
Large
Or
language
is
model development. Yeah.
exactly right? So, and people, and going back to what I said earlier, people in Canada, when they talk about specific research projects, they're very willing to be donating their information to the data if they know exactly what the purpose is. But as we commercialize a lot of these platforms, and that may be really helpful, we have to start asking questions whether how we thought about privacy and boundaries in terms of how we share data will still be applicable now. I'm not saying that they're not. I mean, I think in many ways I might still be kind of like holding on to some of that. But holding on, especially because it is so uncertain and unknown how our information might be shared and used in the future. Because technologies are moving so quickly, and there's so many things that we can now do that we never thought was possible even 10 years ago.
Right, right. And of course, that also leads now into AI, which is the second thing I wanted to cover with you. And this will be the last thing before I get into the three questions that we ask every single one of our guests. So, surprise, surprise. But I think that there is obviously an AI component to the monitoring and behavioral patterns and things like that. But then there's also the interaction, right? And
Mhm.
and we have this scarily growing and accurate ability to kind of have these AI generated avatars serve as someone that can ask daily day to day questions, or how are you feeling? How did you sleep last night? How? But so to both check in on health and wellness, but
Mhm.
then also as this idea of being like a virtual companion.
Mhm.
And I'm not sure if I have a lot of comfort with that, to be honest with you. And I'm not sure. Where do you stand, and what do you think should be? What are the questions that we should be asking as we're sort of
Mhm.
wowed by the capabilities of AI?
Yeah. I think some of what you said earlier applies here as well. Like, are we using these technologies, to supplement, enhance what we are already providing, our loved ones or people we're caring for, or are we using them to replace? I mentioned that I was just at a conference recently, and somebody there mentioned the AI avatar that can talk to people in skilled nursing to remind them to take medication and so on. And they can basically use, so to speak, the voices of these people's family members to say, hey, mom, it's time to take your meds. Hey, mom, it's time to go for a little walk, or so on and so forth. And you can record, or you can use the avatar to say things about making sure that they are eating and so on. Now, maybe that depends very much on that particular person's condition as well. Because you can, imagine that it can calm people if they know, that this is their daughter's voice, or they think this is the daughter's voice, and not somehow kind of get freaked out in terms of, I'm hearing my daughter, but I don't see my daughter. And if it is the case that we're using these avatars to also replace the daughter's visits, in some ways, people might feel even more socially isolated, right? So if we think, my voice is already there, I don't need to go see mom, that's not necessarily going to help with the person's engagement, right?
Right.
So there's that. But there's also that question, I think an ethical question too. If somehow this older adult is really confusing things and believe now that this avatar is the real deal, are we also lying to them? Do we have to lie to them to say that this is really your daughter talking to you? So I think that there might be benefits in some short term, but there are broader ethical questions as well. How do we get consent, if there is consent? And can we deceive people in the use of some of these technologies?
And are you aware of, or should there be, just at the top of the podcast, you talked about kind of a framework for bioethics in general. Should there be a general set of rules or ethical, boundaries around AI in that manner? Like, it cannot be used for this, or it cannot be like for instance, I know that we wouldn't use AI to select job candidates. Should there be when we're talking to older people and the use of these avatars, some sort of an ethical framework that should be generally agreed upon?
Mm-hmm. Right. So many people have been talking about guardrails for AI, right? So regulations in the US or in Canada are still slow, partly because many governments are competing. They want to be innovative. Companies, especially big tech companies, are really worrying, or at least that's what they're saying in the lobbying efforts, that if we have too many regulations to say what we cannot do, it will really slow down innovation. I don't think everything that we invent is innovative, so I will put it out there. But there may certainly still be questions in terms of how do we want to make sure we can protect people. In the US and in Canada as well, not every single device that may have health impact is considered to be a medical device. So not even everything goes through, FDA or other Health Canada for approval. So in many ways, one, we don't even know for sure that they work, and two, we don't actually know what some of the safety guardrails might be as well. So right now, many companies and organizations are, voluntarily deciding that they may not use certain devices. But certainly, there are regulations in the EU, for European Union, for example, really are trying to say that at least for devices that may have higher risk, higher impact, if it is about people's access to jobs or access to healthcare in the medical setting, and that their data security cannot be really assured, that we need to be more careful about it. But right now, at least in the US, it's still, especially for commercial products, it's still more of a voluntary adoption of various kinds of guidelines. So there will be questions, I think, as we collect and use more data to think about how should we have fair ways to make sure that all industry contributors will be abiding. Because if you just have people voluntarily deciding whether they will do certain things or not, then they may think from a competitive perspective, If we do that, but the other companies are not doing it, then we'll lose out.
And Anita, I think it would be fascinating maybe to reconnect with you on a future episode once we sort of
Mm.
have more of these things shaped and to contrast what we're talking about now and it's evolved, because we know that this is moving fast.
Yeah.
But as I said before, we do like to ask our guests 3 questions about aging. And I'm wondering, is it okay if I ask these of you?
Sure.
All right. And just to remind our audience, Anita's book, Live Like Nobody is Watching, Relational Autonomy in the Age of Artificial Intelligence, Health Monitoring. It's Oxford University Press. It's just about a year ago that it was published. So congratulations on that. If
Thank
people
you.
wanted to purchase the book, where can they purchase it?
Many online platforms have that, and you can also go to the Oxford University Press website.
Wonderful. Okay. Question number 1 for you. So Anita, when you think about how you've aged, what do you think has changed about you or grown with you that you really like about yourself?
I think probably more like grown with me. I can't remember if I mentioned at the beginning that I grew up in Hong Kong. So this may be partly a cultural aspect as well. Even though I live in the US and Canada, and which is very much focusing more on individual autonomy, individual rights, and so on, which I, certainly agree with as well. But I think, especially as I get older and have worked with more older adults in terms of what their healthcare issues are, ethical issues might be, that I've become more and more relational. That ties to my book as well. I think that generally speaking, like humans really thrive and flourish in relationships. And I keep thinking about how nobody is born completely alone. Like whatever the context of your birth might be, there was always a birth mother with you. And so as we think about aging as well, if at a certain point we become completely isolated, then we don't fare well. And so from a flourishing perspective, I certainly think about how do we build a community? How do we talked about communitarianism earlier, especially as we get older and may have more physical and mental vulnerabilities. How do we build that village together so that we can really care for each other?
Absolutely. And that's something that we think about all the time. And I think those are really valuable
Mhm.
thoughts. Okay, so question number 2, though, is what has surprised you the most about you as you've aged?
Well, there is, of course, sexism in terms of aging that women in particular often try to see how they can not get older or not look older and so on and so forth. So I still live within that cultural context that is often very difficult to fight. But I think as I get older, I also realize how being able to get old is really a privilege and a blessing in many ways. One of my friends is turning 60 this year, and then we were talking about celebration, and he was like, "There is no way I'm going to celebrate. Like I hate getting old." But I really think that, especially given some of my family situations, that being able to get old is a blessing. My brother and my high school best friends both died of cancer in the last few years in their 40s, and so and as I also see a lot of unrest around the world, that there are lots of casualties. It's not even just like military personnel, but many of people who die and get injured are young people, some of which are children as well. That I really think that being able to get old is not a given and is a blessing.
Wow, that's such a tremendously important thought. And thank you for sharing that with us. But our third question is there someone that you've met or been in your life that has set a good example for you in aging? Somebody that has inspired you, as we like to say, age with abundance.
I haven't told this person that I would mention her. For me, a really good example is Annie Chung, who has been, I think, more than 40 years, the president and CEO of Self Help for the Elderly, which is a community organization that provides support for more than, I want to say, 40,000 seniors in the California Bay Area. She also hosts a affairs television show for Chinese speaking audiences in the Bay Area as well. And I would say that she's probably one of the people whom I know that's most humble and giving, caring, and just generous in terms of really thinking about how to promote healthy communities and really try to empower older adults. So she's not just living and aging abundantly. I think she's really trying to also empower other people to also age abundantly. So I really think of her as an inspiration, particularly in relation to the service mentality to the community for the common good.
That's amazing, and maybe we can get get Annie to be on a future show.
Yeah.
And she's not the only one that's inspiring. Annie, that you are inspiring. We could be doing just such a longer podcast here. I mean, I'm just so happy that you were able to give us this time because we know that you're busy. So my sincere thanks to you for being a guest on the Art of
Thank
Aging,
you.
and most especially, I want to thank our listeners. Thank you for tuning in and listening to this episode of the Art of Aging, which is part of the Abundant Aging podcast series from United Church Homes. And we want to hear from you. Have you heard of bioethics? Are you working in bioethics? What do you think should be the standards for ethical conduct as we enter into this amazing new world of AI and data analytics? Please tell us your thoughts. AbundantAgingPodcast.com. You can also give us feedback when you visit the Ruth Foss Parker Center at www.unitedchurchhomes.org/Parker-Center. And Dr. Ho, where can people find you?
I have a website, and so is my full name and ethics. So it's AnitaHoEthics.com. So you can find some of my current and recent work, and if you want to contact me, and there is also a way to do that there.
Okay, so that's AnitaHoEthics.com. And again, her book,
AnitaHoEthics.com.
AnitaHoEthics.com. And again, her book, Live Like Nobody's Watching, Relational Autonomy in the Age of Artificial Intelligence, Health Monitoring, is available when you go to the Oxford University Press website. So, Anita, thank you for joining. Listeners, thank you for joining.
Thank you.
We will see you next time.